from the American Academy of Pediatrics.
May is Food Allergy Awareness Month, and pediatricians have a lot to be aware of.
From timing of food introduction to treating symptoms of biologics, the field is changing fast.
Everything you thought you knew about food allergies is probably outdated. This space is evolving so rapidly. The conversations I have with families today, I didn't have 6 months ago.
Plus, the AAP's journal, Hospital Pediatrics, is dedicating an entire issue to mental health.
As pediatric hospitalists, we're really at the forefront of tackling this growing crisis, and we were seeing that there were increasing hospitalizations over time that were compounded by the COVID crisis.
These stories and more on Pediatrics on Call, the podcast on children's health from the AAP. I'm Dr. Joanna Parga-Belinkie.
And I'm Dr. David Hill. This podcast is for everyone in the medical community, keeping our children healthy and safe.
It's a show by pediatricians for pediatricians.
But anyone who cares about kids will get a lot out of it as well.
Let's start today's episode with a conversation about identifying and treating food allergies.
I'm curious, Joanna, how are you planning to introduce Zelda to complementary foods?
Oh, great question. She's not ready yet, but when she can sit a little better and is showing interest, I'll start slowly, maybe 1 to 2 new foods a day. And I don't have a history of food allergies in my family, but I know kids like Zelda who have no family histories but develop food allergies somehow. And my kitchen is basically bathed in peanut butter, so I'm a little worried.
Well, I've heard conflicting advice on how to monitor for food allergies, so I'd love to know, if she did have an allergy, would the symptoms be obvious, and would you be able to tell what food it was that caused it?
Given there are so many questions around food allergies, let's talk about them with some experts today. Doctors Rajitha Venkatesh and Dave Stukus from Nationwide Children's Hospital. Dr. Venkatesh is a pediatric gastroenterologist and co-director of the eosinophilic GI Disorders Program and an assistant professor of clinical pediatrics at The Ohio State University College of Medicine. She is the medical director at Partners for Kids, and she's a member of the AAP section on gastroenterology, hepatology, and nutrition.
Dr. Stukus is an old friend of mine, but new to the podcast. He's professor of clinical pediatrics in the Division of Allergy and Immunology at Nationwide and holds multiple leadership positions in his field, including serving on the executive committee of the section on allergy and immunology. Dave, Rajitha, welcome.
Thanks for having us. It's great to be here.
Hi, everyone. Thank you.
Dave, let's start with talking about infants like my baby Zelda. Do you have to worry about food allergies before a baby even starts taking solids and they're just drinking milk?
Yeah, it's interesting that, we don't know why some babies develop food allergies as opposed to others, and they can have an allergic reaction the first time they eat a food, which can be pretty scary. But the good news is the vast majority of infants won't. So we know that, only about 5 to 8% of babies will ever develop a food allergy. So that means 92% of parents never need to worry about it. And thankfully, whenever they do have an allergic reaction, it's typically not a very severe allergic reaction, which I know scares a lot of parents.
And Dave, what are the symptoms of food allergy in infants? Because you mentioned that there is some symptomatology.
Yeah, so there's 2 types of food allergy. We have the rapid onset, which is caused by this IgE antibody, which can cause symptoms within minutes of eating the food, rarely longer than an hour or 2 later. And we can see any combination of big red itchy hives on the skin, some facial swelling, you can have vomiting or even coughing. It's interesting in infants, this was addressed in the recently published 2023 anaphylaxis practice parameters. 2 key points. One, in infants, it may be more subtle. They just may have acute onset fussiness and irritability because they can't really, voice what's going on. But they also took a moment to highlight that it's very rare for an infant to have true severe anaphylaxis the first time they react to a food. I always kind of, talk to pediatricians about how I don't get patients because they die the first time they eat a food. I get patients because, parents notice they get hives or they vomit once and they stop feeding that food. And then Rajitha really, deals with some of the more delayed onset types of allergies and those symptoms that can occur.
Absolutely. That's a great point. And when we see symptoms in infants, particularly from the GI standpoint, it's sort of a range. There's something called milk soy protein-induced allergic proctocolitis, which is kind of a misnomer because when we think about it as an allergy, it's not an allergy in the sense of needing an EpiPen type of allergy. It's more of having a healthy infant present with blood or mucus in their stool. And some that are more severe may have diarrhea, vomiting, irritability, or poor weight gain. And so talking to your pediatrician can be helpful. And in these instances, actually taking out milk protein or soy protein from a mom's diet or using a hydrolyzed formula that has these proteins broken down could be helpful for a short period of time. With the important part being that once symptoms are improving, to then try these proteins back in their diet and not to wait till 1 year of life where we used to wait to see if they could tolerate it. Because we do think that this actually resolves pretty quickly, and this temporary intolerance is actually something that infants outgrow. And most infants definitely outgrow it by 1 year of age. So I think that's one of the things that we see often in infants from a GI standpoint, to sort of the other sort of extreme, which is something called food protein induced enterocolitis syndrome. It is relatively rare and can be really dramatic and frightening for families, and can present in infants less than 12 months of age. So your allergist or gastroenterologist will work with you to learn more if this is what your infant has, but they present with delayed vomiting within 1 to 4 hours of ingestion of the causative food, and the infant can present in shock and acidosis. And this can be something like lethargy or pallor or diarrhea for the infant. And the most common foods for this specific instance is usually cow's milk or soy, sometimes rice and oat, but there are many other triggers out there.
And Dave, when you are ready to start feeding complementary foods to an infant, is there a best way to introduce different types of food?
Well, we always want to make sure that the infant has demonstrated the ability to chew and swallow. So start with the typical purees and cereals and things like that. And now all of the evidence suggests in regards to allergenic foods, start around 4 to 6 months of age once they're eating the other solids. And that includes things like peanut. Obviously not giving them whole or partial peanuts because they're a choking hazard, but you can smooth some peanut butter with some water, mix it into yogurt or applesauce. Same thing with dairy and egg and wheat and so on and so forth. And we don't want to rub it on the skin first. So you're not going to determine. Please, no, seriously, I know it's. We don't want to smother your baby in the food because they're going to get non-specific rashes and it's going to cause a lot of angst and consternation. Just let them eat. They're going to get messy on their own, and just feed them the food. And you don't have to drive to the parking lot of the emergency room before you feed it either. It's going to be okay.
And to move away from babies a little bit into school-age children and adolescents, both you and Rajitha were talking about how GI symptoms can be a part of allergies. So if you have a school-age child or an adolescent who has tummy aches, could that nonspecific sign in and of itself be a food allergy?
That's a great question. Truly, abdominal pain is rarely due to an allergic process in older kids, and often is more due to disorders of brain-gut interaction. And in general, often allergic testing is very low yield in this specific category. But we do think about things like eosinophil GI disorders that tend to run more commonly in kids and adults with other atopic conditions like asthma, eczema, and other IgE-mediated food allergies.
If I could just add as well, I agree. But it's interesting because all of the symptoms that can occur due to food allergy can occur for non-allergic reasons, which makes it really difficult. Yeah. And that's where we come into play with really asking about what's the history? Is it reproducible every single time you eat it? When families come to me and they say, I have no idea what's causing this, that's not a food allergy. They're typically pretty good at picking out 1 or 2 foods that are causing symptoms.
And that's a great point because sensitivities can definitely cause some issues. For example, lactose intolerance can definitely cause bloating, abdominal distension, some cramping, and some loose stools potentially, but certainly does not have any long-term inflammation or long-term implications, but can certainly be symptomatic at the time.
And Rajitha, let's say you suspect that a child has food allergy. Is there a certain test you should order for diagnosis, and does that test vary by age?
Again, I think it sort of depends on the history, as Dave was mentioning. So, for example, in a patient where I suspect eosinophilic esophagitis, so an older child that is having difficulty with swallowing or food getting stuck, or what we call food impactions, the diagnostic test actually is an endoscopy or a sedated procedure where we actually go in and take a look with a camera and take pictures and actually importantly take biopsies of the tissue in the esophagus and the intestine to look for these allergy cells in the intestine.
Yeah, and of course, if you have concerns about that immediate type of food allergy caused by IgE, we have readily available both skin prick tests that we do in the office, or we can do serum IgE tests. Neither of these are screening tests, so we can't just test for everything and see what comes back because we get a lot of false positive results that leads to terrible misdiagnosis, unnecessary elimination, and avoidance. But when the history suggests IgE-mediated food allergy, we have good tests that can confirm that, and these are reliable at any age. If you're old enough to develop IgE food allergies, you're old enough to have an IgE test that confirms that.
And can you talk a little bit more, Dave, about IgE and give us some of the pathophysiology? Because I think that's helpful for pediatricians to review.
Yeah, there's no evolutionary advantage to have food allergies. IgE or immunoglobulin E was, initially developed to help fight off parasitic infections. And the hygiene hypothesis has kind of shown that as civilization has moved towards cleaner urban environments, our immune systems aren't being challenged by all these microbes. So I like to think of it as IgE kind of got bored and then it started, binding to innocuous proteins like, peanut and ragweed and dog dander and things like that. And this IgE antibody is typically bound to mast cells, which are present in every tissue throughout the body and also in basophils in our circulation. So when you have IgE towards an allergen and you're exposed to that allergen, it unlocks those mast cells and basophils rather quickly, which then releases histamine and other chemical mediators that cause all the symptoms.
And Rajitha, it's not just immunoglobulins. Certain cell types get implicated in allergies as well. I wonder if you can tell us a little more about an issue we discussed in episode 162 with Dr. Christine Wastrup-Hurtado, eosinophilic esophagitis. How does this condition relate to food allergies?
Yeah, no, this is a great question and one that's a really interesting topic and a disease that's actually relatively new. It's really only been around for about 30 or so years. And interestingly, it is a food allergy induced condition, but not in the same classic IgE-mediated pathway. So this is a condition where we have eosinophils or allergy cells that do serve a purpose in the gut. As Dave mentioned, they, protect us from parasites and among many other things. And we actually do expect some levels of eosinophils in our gut. However, in the esophagus, they don't really serve a purpose. And so in eosinophilic esophagitis, these cells, when they're there, they cause a lot of havoc and can result in inflammation that then results in stickiness and can actually ultimately result in fibrosis or narrowing of the esophagus. And we do suspect that food triggers or specific proteins and sometimes environmental triggers can actually induce this response. And one of the potential treatment options is to remove milk protein from the diet.
And you mentioned the esophagus, but can these eosinophils invade other parts of the GI tract as well?
You got it. Yeah. So it is a relatively rare disease. And when we think about non-EOE EGIDs or eosinophilic GI disorders, they're actually even more uncommon. But absolutely, we can have higher numbers of these allergy cells in our gut that can then result in things like diarrhea, abdominal pain, weight loss, poor absorption, for example. And the treatments can vary depending on where they're located and what your symptoms are. And thankfully, there are many new things coming out that are going to help us manage these long-term chronic conditions.
When you talk about new things coming out from management, are you talking about omalizumab, Dave?
Yeah, so when we talk about IgE-mediated food allergies, it is an exciting time because we do have an FDA-approved treatment option called omalizumab, which we've used for over 20 years for treating allergic asthma and other allergic conditions. And what omalizumab does is it binds the IgE antibody. So as we discussed before, if the IgE is what's binding to the allergen, which is causing all of the symptoms, well, if you actually bind that up in these clusters, it can't actually react to the allergen. And in the trials with omalizumab, they demonstrated that children who are exquisitely allergic. They had multiple food allergies and they were reacting to very small amounts of protein, like less than 1/3 of a peanut. After 6 months of treatment with omalizumab, they increased the threshold that they could tolerate before they experienced an allergic reaction. So this is not a cure for food allergy. This doesn't allow people to start eating their food freely in their diet, but it offers that sort of bite-proof protection that most people want. So it's a great option for people to discuss.
And what about other new treatments? Rajitha?
Well, as of May 2022, we actually had the first ever FDA-approved medication for EOE called dupilumab, which is a biologic medication and an injectable medication that was approved for 12 and above for EOE in kids and adults. That is actually now been incredibly helpful for many of our patients who have other atopic conditions as well, because it is also approved for things like asthma, as well as eczema, and has now been approved for ages 1 and above as well. And more recently, a medication called Eohilia, which is a version of a swallowed topical corticosteroid, budesonide, that is pre-mixed. So a patient can swallow it and have it coat the esophagus. And that was just approved this year. So we have some great options now that are finally approved. So that was the first oral approved medication. So now we have hopefully some other ones coming down the pipeline in the future as well, but have a much more very varied approach for our patients and have a great opportunity to do some shared decision making with patients and families in deciding which is the best approach for them.
If I could add very briefly, I love what Rajitha said, because our patients and children who have food allergies and eosinophilic esophagitis, it's not like that's the only thing that is impacting their lives. And they often have frequent comorbid allergic conditions, whether it's asthma, environmental allergies, atopic dermatitis, things like that. So now that we have these biologics, we can actually treat the whole person, which is fantastic. And it's very exciting.
This is such an exciting time for allergies. And you've both given us a lot to digest today. But do you have any last takeaways? Dave, let's start with you.
Everything you thought you knew about food allergies is probably outdated. This space is evolving so rapidly. The conversations I have with families today, I didn't have 6 months ago, whether it's desensitization with oral immunotherapy, treatment with omalizumab, just our understanding of risk associated with that diagnosis and prognosis, it's all changing very rapidly. So I encourage everybody who's interested to read the latest and greatest practice parameters and guidelines, and keep in mind that it's probably going to all be different 6 months from now as well.
And Rajitha, any last takeaways for us?
Yeah, no, I think isolated GI complaints are common presentations to the pediatrician, are not often allergy mediated, but could be. And I think this is where, certainly refer to us as allergists and gastroenterologists. We're happy to see these patients and work through the history and think through next steps and whether there are diagnostic studies that would be helpful, such as an endoscopy or skin prick test or blood tests. But again, these are very guided discussions thinking about the history. So, we're happy to sort of think through some of those next steps and really be thoughtful before heading down a certain pathway. So lots to sort of digest, I agree, and many new things coming out. So a really exciting time for GI and allergy together. And we work together often. We actually have a combined program here, Nationwide Children's, with GI and allergy, and among also psychology and social work. So really having a multidisciplinary team is so important to have these conversations and crosstalk across specialties.
Well, Rajitha, Dave, thank you both for giving us so much to chew on today. And I think Zelda thanks you too.
She's excited to start solids. Thanks, guys.
It's our pleasure. Thank you.
Thank you, everyone.
To learn more about food allergies and eosinophilic gastrointestinal diseases, go to aap.org/podcast.
Coming up, we'll look at a special issue of Hospital Pediatrics devoted to mental health. I'm going to reveal my age here, but when I graduated residency in 2014, I had only done a small handful of mental health admissions on the pediatric wards. I trained at Children's Hospital of Los Angeles, so we were busy with a variety of chief complaints, but mental health was not top of the list.
Well, Joanna, we graduated residency at virtually the same time. It was 1998 for me. And if I did any mental health admissions, I could count them on one hand. But now I'm doing a ton of them, and I certainly see the change over time.
So you are admitting a lot of kids for mental health issues now?
Oh, yeah, I think it's almost every shift. And that's why I'm really looking forward to a special issue of the AAP's journal, Hospital Pediatrics, dedicated to mental health care in the pediatric hospital setting.
Our guest is Dr. Christopher Russell, someone who trained me at Children's Hospital Los Angeles, but is now an associate professor of pediatric hospital medicine at Stanford Medicine Children's Health and attending at the Lucile Packard Children's Hospital and associate editor of Hospital Pediatrics. He's here to talk about some highlights from that issue.
You mean Chris is going to rustle up some articles?
Ooh.
I thought that was great. Chris, welcome.
Thank you for having me today. I really appreciate the invitation and the time to talk about this.
I mean, Chris, you heard David and me talking about how we didn't do a lot of mental health admissions in our training and residency, and it seems like they're winding up now on pediatric hospitalist wards. Was that the impetus for doing this special issue?
Yeah, as pediatric hospitalists, we're really at the forefront of tackling this growing crisis, and we were seeing that there were increasing hospitalizations over time that were compounded by the COVID crisis.
And let's talk about the numbers. How many admissions are there now, and how long are these patients having to stay in the hospital?
Well, you're right, Joanna. The number of admissions to both our emergency rooms and acute care hospitals is increasing. 1 in 8 emergency room visits for a pediatric patient is due to a mental health or behavioral health issue. And now 1 in 5 hospitalizations are due to acute behavioral mental health issues.
And then what's their length of stay when they are admitted?
Yeah, we have an article by Dr. DePore and colleagues in our special issue that's looking at factors associated with prolonged mental health admissions at U.S. children's hospitals. And what they were looking at is children who are hospitalized for more than 14 days and trying to identify factors that were associated with that. Factors that were associated with that included race and ethnicity, so Black children and Asian children were more likely to have a longer length of stay, and then certain mental health conditions, which included eating disorders, autism spectrum disorders, and other mental health issues such as schizophrenia. The really interesting thing that they found about this article was that the number of mental health conditions that you had when you were admitted was also associated with your longer length of stay. So the number of conditions that you had, and it wasn't just your mental health conditions, it was also your medical conditions. So we saw increasing length of stays for patients who had comorbid mental health issues as well as medical complex chronic conditions.
You know, as a fellow hospitalist, I'm wondering, how much training did you get on mental health care for patients admitted to your service? And do you think most hospitalists now are prepared to deal with this rising number of pediatric mental health admissions?
When I was a pediatric resident at UCSF, we did 1 month of developmental and behavioral pediatrics, and then we saw patients intermittently on the floors who needed medical stabilization as well as in the emergency room. But I got no formal training in psychiatry or psychology. And really, there is probably insufficient training that's focused on behavioral health and psychiatry for pediatric residents. There's evidence that the majority of pediatricians feel uncomfortable taking care of children with serious mental and behavioral health issues, despite it being an EPA for our pediatric residents. What's interesting is that the ACGME is now proposing some increased training in mental health and proposing adding 4 weeks of focused outpatient mental and behavioral health training in addition to our DBP month. But that's creating a lot of controversy, and there's a lot of discussion about how we're going to be able to do that given the lack of child psychiatrists and other mental health providers to train all of our pediatric residents.
And how that would shift training and take away from other areas. As a neonatologist, this is a big topic for us too. But I am curious, how can we change our current systems so they work better for patients who have both medical and psychiatric diagnoses? Is there any engaging research in this area?
Yeah, I want to point out that children who have combined mental and behavioral health issues as well as medical conditions are really high risk for being hospitalized for longer periods of time. One of the articles in our special issue by Dr. Yankova and colleagues at Yale highlighted really low value care that we're providing for patients. And they highlighted a case where they had a patient who was admitted to the hospital and after medical stabilization, which took about a week, had to remain in the hospital for almost a year, because they could not find placement for this patient. They could not find a safe placement that could take care of their medical issues as well as the patient's behavioral issues. And that's really taxing. That puts taxing not just on the families who continue and the patient who continue to be hospitalized in a place that is, not ideal. It also creates challenges for the staff and clinicians who are caring for these patients in the hospital, because it creates a lot of moral distress seeing patients who are confined to a room, who are unable to do things that they normally are able to do. And even thinking about this boarding process as almost incarceration and taking away people's rights because they're not able to do what a typical child would do.
With a rise in the prevalence of autism spectrum disorders, I think it's something like 1 in every 36 children now. Do you have advice for pediatricians managing affected children in the hospital setting, which can be, destabilizing for anyone, but I imagine especially for these children affected by autism spectrum disorder?
I think that's a really great question. That's really complicated. Our pediatric hospitals are generally not set up for children with autism in terms of decreasing stimulation. But I think one of the articles in our special issue by Dr. Klein-Peter et al. Out of Baylor, what they did there is they really redesigned how they approach the care for children with autism and autism spectrum disorder. And they thought about delivering holistic care for these children and youth, as well as their families. And I think one of the things they did was they moved from our sort of typical model where we have the same room, the same approach for every patient who's hospitalized, to really thinking about designing environments for these patients who are hospitalized for a long time in care settings that may not be ideal for their conditions. Really trying to ensure safety for the patient and for the family, decreasing escalations and aggression, and working closely with a multidisciplinary team of psychiatrists, psychologists, behavioral therapists, and the pediatric hospital medicine team, as well as our nurses and other therapists, to provide care that is compassionate and patient and family centered while the patients are hospitalized. And despite this, patients with autism who have severe behavioral issues can be hospitalized for months to years. We did have one patient who I had hospitalized for over a year because, again, we could not find placement that was safe for him as well as the people who were caring for him, and ultimately had to be placed out of state because we couldn't find a facility in our area that was able to accept him.
Wow. And that just really highlights some of these challenges that hospitalist medicine pediatricians are facing. So thank you for doing that. And I wanted to close on an article that actually seems to tie it all together by proposing a whole framework for addressing issues at the intersection of mental health and hospital pediatrics. And I love the name, Human-Centered Design. Can you tell us about what human-centered design entails?
Yeah, I agree that human-centered design is a really interesting way to approach complex problems. And human-centered design is defined as an approach that puts the human needs and capabilities and behaviors first, and then designs things to accommodate those needs, capabilities, and ways of behaving. And it really seeks to center, as the name says, the needs of our patients and their families into the quality improvement process, trying to really integrate a holistic approach to improving these complex systems. So I really think about it as a way to approach how you can improve the care of these patients and develop rigorous quality improvement and implementation science methodology to really meet the patients and families where they're at. In our issue, Samantha House and colleagues at Dartmouth Hitchcock Medical Center did a really fantastic job of using human-centered design to improve care for youth that are experiencing psychiatric boarding. As we all know, patients who have acute psychiatric illnesses who are being medically cleared, and after they're medically cleared, they sometimes remain in the hospital for a prolonged period of time awaiting a psychiatric placement. And Dr. House and her colleagues noted that this was a time that was really static. We weren't actually advancing the care for the patients. We were just basically keeping them in their rooms without any tablets or phones and keeping them safe, but not actually treating the root cause of their admission, which was the acute psychiatric illness. And so they took the 5-step approach through human-centered design to really work with families and patients throughout the entire process to design a new innovative program called iCare, which stands for Improving Care, Accelerating Recovery and Education, to help these patients while they were stuck in the hospital to move and improve their psychiatric and mental health.
That sounds like a process that should be obvious to us all, but I'm not sure that we really embark on it as often as we should or could. Can you tell us anything about the specific outcomes in this particular case, or how that might impact our care in a much more global way?
I agree. I think that it's something that we think that we do really well, which is integrating the families and patients' perspective into how we design our interventions. But oftentimes it's really a top-down process. So what I really think this group did well was really integrating the patient and family perspective throughout the process. And what that does is that helps to lift the family voice, ensure that voices that are minoritized or marginalized who aren't heard are being uplifted and being equated with voices that are in the majority who sometimes are more likely to speak up or feel comfortable speaking out when they have an opinion. And so I think one of the ways that human-centered design can really help is to decrease disparities and promote equity by designing systems and policies that serve the best interests of all patients.
Well, Chris Russell, I appreciate your serving the best interests of patients and our colleagues by talking with us today. And I want to thank you so much for taking time out for that.
I really appreciate the invitation to speak today.
To read the articles from today's program, go to aap.org/podcast.
At the end of every episode, we like to leave you with something positive or enlightening. We call this segment Say Ah. David, what's your Say Ah this week?
All right, Joanna. So in our neighborhood at this time of year, we have these little birds with little ringed necks called killdeer. And for those who are concerned, they are no danger whatsoever to ungulates. Instead, that's the sound some people think they make. I don't really hear it, but that's what people say. They have this amazing behavior when they're protecting their nest, their eggs, their babies. The mother will run away from the nest and then pretend she's injured. So she'll flare out her wings and tail and become really visible and kind of lie over on her side like she's hurt. And that's designed to distract me and my dogs from the nest. But we know this, so I go back where she came from, and I saw 3 perfect little eggs. I can send you a picture of them. And now that I know where they are, I really hope we're going to watch them hatch and watch your babies grow up. So I'll let you know.
Oh, that's so cute. Well, talking about eggs made me think of food. And, probably our listeners don't know when we record these podcasts, but it's like about lunchtime now. And I'm about to eat one of my favorite hoagies, as they're called here in Philadelphia. And during pregnancy, I couldn't eat any cold cuts because I was worried about the theoretical concern of listeria because I'm a neonatologist. Probably it's not there. You're probably fine if you've had cold cuts in pregnancy. But I avoid them. So now I'm about to chow down on like my favorite turkey sandwich. And for some reason, that is my say ah today, is this turkey sandwich.
That's just say yum. I'm a little jealous. I kind of want that sandwich, but I'm in another city. We have no hoagies. That's it for today's episode. If you like Pediatrics on Call, please subscribe on your favorite podcast app and help us spread the word. Follow us on Facebook and Instagram at Pediatrics on Call.
Pediatrics on Call is a production of the American Academy of Pediatrics. Our producer and editor is Ann Johnsos. Our audio engineer is Doug Nagel. Joe Puskars is our associate producer, and Susan Martin is our executive producer. Our theme music was composed by Matthew Simonson. Join us next week when we'll look at confidentiality in the treatment of adolescents.
We'll talk to Dr. Richard Chung about a new policy statement and technical report. I'm Dr. David Hill.
And I'm Dr. Joanna Parga-Belinkie. Thanks for listening. Hoagies.